Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all that ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare delivery and technology. My guest today is Mike O'Neill. Mike is the CEO of MedicaSoft. MedicaSoft is a provider of cloud-based, HIPAA-compliant software solutions and health information technology services. Their products and services include a high-performance interoperable healthcare data platform, which is built on the HL7 Fire Standards. We'll talk about that in a little bit. But the platform also includes advanced reporting analytics. They have a comprehensive personal health record, a high-performance electronic health record, and direct secure messaging services. Mike, welcome to the Tate Chronicles.
I'm glad to be here.
I was looking at the your website this week, Mike, and reading some of the blog posts, and one of the quotes there I really liked, and it said, "In healthcare, plenty of data exists. The question is, can we use it to bring the right information to the right person at exactly the right time in the overall decision-making process?" I think that's really the challenging of interoperability. We got all that data out there, but can we get it to the right place at the right time? And so to kind of go into the details of that, let me kind of ask you an overarching question, Mike. Why is the fire standard so significant? And is it significant? What will the fire standard do to help the exchange of data?
Yeah, so I do think the fire standard is significant in addressing the very topic that you mentioned there. I think that in the healthcare industry, the trend is towards getting access to more data and more different types of data. And I think that's true whether we're talking about improving care and improving outcomes, or we're talking about improving efficiency and different reimbursement models and so forth. It's no longer the old days where you could build one system that had all the data that it needed in its own silo, if you will, its own database. More and more, we're looking to get access to data that may be distributed across systems, even if you think of your own health records at different facilities and different healthcare providers that you've visited. How do we bring that together into a single record, for example? So when we're faced in industry with a challenge that we need to get together data from different sources and different uses, how do we do that? What's the common language that we use to do that? And what are the methods that we use to actually move the data from one place to another? The nice thing about the HL7 Fire Standard is it gives us a way to address both. There's a way to represent or model that data. The data model part of the Fire Standard is, I think, from a developer's point of view or technology folks like us here at MedicaSoft, it's very clean in terms of how do you build a system that implements the standard, the way of modeling or representing data. So that the data model part of FHIR makes it easy to deal with all kinds of different data from different sources. Then how do I move it from one place or another, or how would you and I exchange data? That's built into the standard as well. And it's built in a way that's compatible from a technology point of view with the way we build cloud-based, web-based applications today. It's API-based, and FHIR, as part of the standard, defines the API or the interface that you would use to exchange data. So that's maybe a longer discussion. You can sum it up by saying, hey, FHIR gives us a good way to represent data in a common format and a good way to exchange data in a common modern form.
One thing, Mike, that intrigues me about all this is that we're gathering so much healthcare data every day. Just gigantic realms of data is being gathered. And if used properly, it can help at point of care, direct care of a patient, if we can get their record there. But also that data, if it can be gathered in real time, can help with a public health crisis, such as the one that hopefully we're at the tail end of, the COVID-19 global pandemic. If we knew, if policies and public health actions could have been based on accurate information as to where the outbreaks were with greater specificity and who had even been vaccinated and who hadn't, that data came in such a, for lack of a better word, a fuzzy manner that at the state level and certainly at the federal level, those experts were kind of flying blind because they really didn't know what was happening out there. And hopefully that data will be available in a way in the future that we'll be able to respond better to those kind of events. Go ahead. I'm sorry.
I was going to say, I think that's definitely true. I think the pandemic showed us the value of having electronic data that's interoperable, that we can exchange where that's available, and the shortcomings when we don't have access to it. I think to link to our previous question here about the nature of HL7 Fire, a standard like FHIR does help in this regard, in that if in a provider's system, let's say the electronic health record where they're recording your care, if that is efficient in being able to store data and share it, the fact that you received a vaccination or haven't received a vaccination, or what symptoms you had and to what extent they were serious or versus mild, to the extent that those are electronic and stored in a way that's easy to share, they can be made available, whether it's to the state, let's say your public health department, or to a national effort, or even just from one doctor to another that's involved in your care. To the extent that we have electronic data represented in a standard format in a way that can be exchanged. And it's worth saying, sometimes data can be exchanged, but it's not what we would call interoperable. I might send you something that you don't know how to interpret, for example. We've accomplished the technical requirement that we exchange the data, but if you don't know how to interpret it and can't use it, it's not interoperable. So this is an area where standards and standards like FHIR really help us. It's one thing to send data from one place to another. It's another thing to make sure that the person who gets it, it means the same thing to them as I intended it to mean when I recorded it. In any case, if we're able to make progress on this kind of interoperability, then in a pandemic situation or in a population health situation where we want to pull together a large amount of data across a county or a state or the country, we can do it. We have a shot at bringing it together. We have a structured way to do things like protect patient privacy, which sometimes can be overlooked when we talk about the interoperability of data, but get the real content of what are the health outcomes that are being achieved, or where are the hotspots in looking at where the spread of a pandemic is going. Being able to aggregate data, protect patient safety, and trust the contents, those are things that are much easier to do if we can lean on standards.
You know, one other aspect of all this, or benefit of all this data that's being aggregated, hopefully it's being aggregated, it's certainly being collected, that even if it's historic data and is not being used to treat a patient today or this week, hopefully that data can be used in some manner in something like clinical trials to see what treatments or what procedures possibly work better. Now, I'm not saying you can do a clinical trial just without historic data, because just because somebody is put on medication doesn't mean that they're being compliant and there's good adherence and they're actually taking it. So it's not exactly the same, but hopefully something that's at least collateral with clinical trials, something can be gained, some patterning, or even if it's just demographic data, if we have people's area codes and knowing the frequency of certain cancers, so, that kind of information, public health information, a lot of opportunity there. But before we get away too much, I want to talk just a little bit about MedicaSoft. And so we mentioned a few of the services and products that MedicaSoft offers. Who are your customers? Are they hospital systems? Are they third-party insurance companies? Who are your customers?
Yeah, it can be both. The first market that we are serving today is actually state level or regional health information exchanges. So in many states or regions of the country, health information exchange, or an HIE, is set up to connect to the healthcare systems, hospitals and physician offices in that region, and collect their data. Basically, they will send patient data there. If you can think of it this way, if each hospital sends data, then when the hospital is treating a patient, they can access the aggregated record or longitudinal record that the HIE may have. So there's some benefit to me as a provider. If I share my data, then what I get back is aggregated data. I get back more of the patient's record that I may have in my system. In order to do that, there are a number of things beyond just being able to store data. We have to be able to take care of things like patient matching. How do I make sure? If I'm receiving data from, let's say, different doctors' offices, how do I make sure that each piece of data that I get gets associated with the right patient? We all know there's, in my case, there are many Mike O'Neills across just the state of Virginia where I am now, let alone the country. How do we make sure that my records aren't mixed up with another Mike O'Neill? That kind of patient matching is a service that we provide to help sort out and associate data with the right patients. To make sure that data is understood properly, sometimes we transform it or take data that might be recorded in a local format or proprietary format by a hospital, and we'll translate that to a national standard so that anybody who accesses it gets the same meaning. And there are a number of services like this around the data itself that we provide.
Yeah, the issue of patient matching for anybody who's in our field is a constant because there's federal legislation that says, I imagine it's federal legislation, that Social Security numbers cannot be used. So other types of matching have to be done. And of course, we want to make sure that any records that are received or reconciled or aggregated belong to a known entity. And there's no cross-pollination of data there. Let me say that for those in our audience who maybe have just joined us in the last few minutes, this is Jim Tate of the Tate Chronicles, and I'm speaking with Mike O'Neill of MedicaSoft. Something you mentioned a minute ago, Mike, about these health information exchanges. Some of them are regional wide, some are statewide, some are citywide, probably, I imagine. Some are hospital system wide. And we have not really had a national health information exchange which has scaled successfully. I imagine you would agree with that. But we've got something on the horizon. Well, it's more than on the horizon. We've got something right in front of us called TEFCA. What are your thoughts on TEFCA and its ability to be a national health information network?
Sure. Yeah, that's a great one. So you are totally correct that we don't have at a national level a health information exchange if we think of a repository where all of our health records go across the country. That is not something that we do. There are some networks that you can use to exchange records from one hospital to another that are establishing a nationwide footprint. If you're familiar with eHealth Exchange or Commonwealth or Care Quality, these are attempts to create a network that would allow two hospital systems to share a record. So if I'm visiting one hospital, it would allow a doctor there to go to another hospital and retrieve my records from there. The way that I think, and that we at MedicaSoft think about TEFCA, is in the arc of interoperability in the industry. You could think of where we started with what's been known as the meaningful use requirements. So initially, the government encouraged hospital systems, healthcare providers, to use electronic health records. So the starting point was use software, store data electronically. Mm-hmm. And over the years, there have been steps towards what we would call interoperability, starting with making sure patients can access their records. In the shorthanded, the industry became known as a view, download, transmit requirement. So hospitals would say, first, I have to implement electronic health record software. Then I have to make sure patients can access the records. And there was another step to say, you actually have to make that data available via an API so that other applications, specifically patient applications, can connect. Then it became a requirement to use HL7 FHIR for that API. TEFCA is almost like the next step to say, if you've been doing these things, you have your data electronically in an EHR, you've been exposing is the term we use, or making available APIs. This is leading you along the way towards interoperability. The next step is, I want you to connect to a network that will allow you to exchange health records with other providers. And TEFCA is the infrastructure that we would need to make sure there's a definition of what is a network and what does it mean to connect and what does it mean to participate. TEFCA gives us the framework to allow that kind of health record exchange.
That is a great description of it, Mike. And TEFCA is certainly not a service or product or vision or dream that came up overnight. It was part of the Cures Act, signed into law in 2016. So it's been the planning discussion stages for a long time. And some folks describe it as a network of networks. And these networks are going to be what they call QHINs, Quality Health Information Networks. The first ones, of course, there's an application process around security and privacy and functionality. The first networks are expected to be named maybe late in the summer or early in the fall. Hopefully there'll be traction there. Now, it's voluntary to be for a hospital or a provider to be hooked up to one of these qualified health information networks. But we hope that there's enough return on value or possibly third-party insurance companies, maybe insist upon it or will reimburse more if providers are hooked up to the TEFCA network. I mean, we're just going to have to wait and see about that a little bit. But I know that initially, some of the things I really like about TEFCA is it has to be, by the rules, backwardly compatible. So all that data that's in the existing health information exchanges, I guess the old-timey RIOs, they call them, Regional Health Information Organizations, all kinds of names for those groups. It has to be backwardly compatible, and there has to be individual access. So an individual can go in and access the information. If you can access one QHIN, it's connected to all the other ones. So it's going to be pretty exciting to see this roll out over the next few years.
I think so. I think it really will move the ball forward to being able to, as a patient, to first of all be able to have access to any of the records that your providers have. It's a key thing that you mentioned there, that TEFCA includes a provision for patient access. But for providers, just to make it easier for them to feel that they've gotten more of your health records, more of the total picture of your health when they're treating you at their facility. This should make a difference, hopefully for patient outcomes, but it also allows more efficiency, let's say. It should reduce the number of tests that are done just because a provider doesn't have the results from the test that you had done a few months ago. So there's an efficiency aspect to it as well.
One thing that is fascinating to watch it as it is being birthed. I guess this year is actually being birthed because some of the final regulations were published in January, and the applications are being accepted for the initial wave of QHINs. But they're not going to immediately try and go 1,000 miles an hour. So some of the data elements that will eventually be exchanged don't necessarily have to be exchanged in the first wave of the timeline. I think eventually such things as reimbursement. I could be wrong, but I think reimbursement is not required to be exchanged in the first wave. So there's some, and fire also is not required initially. And so we're kind of easing our way into it, and that sounds like a pretty good way to do it.
I think so. The encouraging thing for folks like us is that TEFCA is being formed in an environment where fire is it's still emerging, but is beginning to take hold and beginning to see implications. So although TEFCA doesn't require you to use fire on day one, there's already thinking about how does fire fit into the TEFCA story? How would you make accommodations for, how would you take advantage of it later as it becomes more prevalent? But you're able to start today with where the industry is in terms of health record exchange, which is largely what we call document-based exchange, query-based, document-based exchange.
Right.
With networks like Commonwealth or eHealth Exchange. So I think it's a good plan to say what TEFCA has to start today in the world we live in, but have an eye out for what is the future when exchange via API, such as Fire API, becomes more prevalent.
Mike, you mentioned the word ARC a few minutes ago, ARC of interoperability. I like to always ask folks I'm talking with a similar question has to do with trajectory of interoperability. To me, the first instance of interoperability, I'm dating myself here, but is when medical practice brought in the first fax machines. The fact that you could call another practice and say, fax over some information, that was a giant leap forward to me. And then we had, as you mentioned, the meaningful use stimulus plan, which drove the adoption of certified technology and the requirements of certified technology for codified, discrete, structured data. And then around, as you mentioned, the APIs to support interoperability. So that's my question for you. Where are we in the arc or the trajectory? Are we kind of reaching a plateau? Is the steep curve over with? Where are we in all this, Mike?
So I don't think we're at a plateau. I think we are still on the curve. I think that we are in the part of the curve where we're putting in place plumbing for how we share data, how it gets sent from one place to another, how we address what's sometimes called semantic interoperability so that what I send you actually makes sense and so forth. The next part of the curve, I feel, is to make it so that the user, and the user sometimes might be patients like you and me, might be your doctor, nurse, someone like this. How do we make it so that they don't even have to think about the plumbing? They just have the data that they need when they need it, almost the quote that you started off with. Right now, you kind of have to be aware of the plumbing. And that's not a bad thing. That's actually a sign of progress. So I think we're working our way up the curve. I feel like it then falls to folks like us here at MedicaSoft, other technology vendors. How do we take the next step so that we take this interoperable data and let users use it in a way that they don't even have to think about the plumbing that's behind it? That's really when we'll get to the plateau.
You know, and Mike, that's probably a good place to end this conversation on an upbeat note. But before we sign off, If folks want to find out more about MedicaSoft, where should they go?
Well, they can visit our website, which is medicasoft.com. And there's information about our products and services, of course. And we try to put information in our news section that is about industry and topics such as what we're discussing here today.
Well, great. Well, to our audience, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Mike O'Neill of MedicaSoft. Mike, thanks for coming aboard today.
Thanks, Jim. I really enjoyed the discussion.
I did too. You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.